Good afternoon, everyone. I'm Brett Perlman, President and CEO of the Center for Houston's Future. Welcome as we continue our series of discussions with national and local experts on the pandemic leadership and community equity, with today's webcast on building trust in communications around the pandemic. This webcast is going to focus on ways to build public trust in communicating about the pandemic and what strategies policymakers and health officials can use to provide fact-based, simple communications to the public about COVID-19. The Harvard philosopher Michael Sandel recently said that trust matters in a pandemic. Not only trust in scientific information and medical advice the government provides, but trust among citizens. He added that perhaps the greatest single responsibility of leaders in times of crisis is to inspire such trust. So one of the challenges that the public faces in responding to the COVID-19 pandemic is who to trust and how to understand the overwhelming amount of information, often from sources that are inaccurate, out of date, and unclear. So today we're going to speak with panelists who are not only about what is required to get the virus under control, but how we can rebuild public trust in solutions to the pandemic and how we can appropriately communicate with the public about these solutions. We'd also like to start a dialogue with you. So please type your questions for the panelists into the Q&A box in the Zoom website rather than use the chat function. We have really four great panelists to have this discussion with today. First, Dr. Asaf Biton, who is Executive Director for Ariande Labs, which is a joint center for health information innovation at Brigham and Women's Hospital and the T.H. Chan School of Public Health, is with us. One of Ariande's lab's focus areas has been to communicate simple and easy to use information to the general public to apply real-life scenarios to help mitigate the exposure and spread of COVID-19. Welcome, Asaf, to the webcast. Dr. Emily Brunson, who is a medical anthropologist at Texas State University, whose recent National Science Foundation report, Readying Populations for the COVID-19 Vaccine, describes a roadmap for vaccine communications and provides recommendations on how to advance public understanding of access to and acceptance of COVID-19 vaccines. Welcome, Emily. Alex Lopez Negrete is a nationally recognized business leader and owner of Lopez Negrete Communications, the nation's largest independent Hispanic-owned advertising and marketing services agency. He and his firm have played an instrumental role in developing the evolution of the City of Houston's COVID-19 communication strategy, targeting Spanish language communities. And finally, Christy Feig is Managing Director of Communications and Advocacy with the Rockefeller Foundation. Christy brings over 25 years of experience in communicating information during public health emergencies, including stints at the World Health Organization and the American Red Cross. So thank all of you for joining us for what I think is going to be a really interesting conversation. So Asaf, let's start with you. And let's start talking about where we think we are today. It's now September 1st. We're at the end of the summer. COVID-19 has been with us for 7 months in the United States. People are tired of being at home. School opening has been messy. Most of us would like nothing more than to return to some semblance of normalcy. And we're still hoping for a vaccine. And yet we hear that there might be a second wave. Last time we talked back in May, we talked about the combination of hygiene measures, screening, distancing, and masks as the key to reopening. How do you think this has been working over the last few months? And what is it going to take so that we can move confidently forward to a true reopening of our society?
Thanks, Brett. Thanks for being here. And it's really lovely to be with the fellow panelists and with all of you online. Well, so you asked an important and direct question. How are we doing with the playbook to control COVID-19? Playbook hasn't really changed too much, but I think it can be said we're not doing all that well across much of the US. You know, we're still actually in a first wave. The curves that you may see nationally may look like a double dip, but they're not a second wave in the original communities that got hit first. They're the continuation of one big surge as it surged from the coasts to the south and the west and now up into the upper Midwest. It just keeps going and going. It's a relentless virus. It's a genome packed with 15 genes that work in ruthless biological efficiency to do their business. And it has been, as a clinician taking care of patients and as a public health leader, an extremely humbling and sobering and tiring experience. And so your question's really around how do we get control of this thing, and all the measures that we talked about, distancing, testing, et cetera, apply. They're critical, especially face masks right now, and depoliticizing and reducing the heat around the face mask debates is really important proximally. But distally, for all of us to get back to our lives as they were or will be, and for all of businesses to return to their new normal, will obviously require not just a vaccine, but multiple vaccines in multiple waves. Most vaccines that are on the docket right now in phase 3 trials will likely be vaccines that require multiple doses, and also have production lags, even with the advanced purchasing and manufacturing commitments put forward. So, we have a tough road ahead of us. I think that we'll get there, but this is not going away in a few short months, unfortunately.
Okay. If you were to look out 6 months from now and looking at, I think the federal government with Operation Warp Speed, which is the vaccine development program, has talked about delivering 300 million doses by January 2021. What factors need to be in place in order to reach that goal? Do you think that's a realistic goal, or do you think that this is going to be, that we're going to still be in this same sort of spot if we look out 6 months from now? Where do you think we'll be?
I think COVID teaches a person that all prognostication in these times must be done with deep humility. So I'll give you a guess, but it is a guess, and perhaps the more you know, the less sure you are about any of these guesses with such complex dynamics. What needs to be in place, first and foremost, is a vaccine that's effective, that's proven to be effective in phase 3 trials, that's not rushed in the dead of night to some sort of end around emergency authorization without the requisite safety and efficacy data. And we need to say that very clearly, and I'd like to really detach it. This has nothing to do with politics. This has everything to do with the topic of the webinar, which is trust. If we intend for our communities and our vulnerable populations, elders, healthcare workers to take a vaccine, it has got to be proven to be at least minimally effective, meaning at least 50% effectiveness in the studies, and with a minimum of untoward significant side effects as much as possible. If we don't get that right on the first goes around, then what happens is that, and we've seen this over and over in the history of public health, that populations will not be interested in future vaccines, even if they're proven to be effective. So I really am excited to discuss in this panel with communications, public health, and anthropology experts on how we get to building that narrative and that fact of trust around the vaccines. And I really want to emphasize the plurality of that. It is very unlikely that there will be one vaccine that works amazingly and effectively by January. It is much more likely that over the course of the next 6 months, a few vaccines will come out with middling to hopefully more than middling effect. And then the question is, will their production and manufacturing capacities have been able to be built out to the extent that we can start to distribute tens of millions of vaccines in an equitable allocation strategy that makes sense public health wise, and that is fair and just and necessary from a public's perspective.
Okay, so it sounds like a long road to hoe that we have ahead of us.
It's a medium road.
Okay. One of the things I want, you've written about this, and I want to even introduce not only the U.S. context, but maybe the global context is because you've written a little bit about vaccine nationalism. Can you explain a little bit about that and what some of the obstacles you see for distributing the vaccine not only in the U.S. but globally? Talk a little bit
Sure.
about
Vaccine nationalism refers to a troubling trend that we're seeing around the globe in which a number of countries uh, are ignoring the interconnectivity and the global nature of this pandemic in our modern world. And so what it refers to is countries buying up the rights or the ability to produce particular vaccines, individual vaccines that they then exclusively license, exclusively own, keep to themselves, distribute to all of their citizens first. And the reason it's troubling is because, again, this is a vaccine that doesn't care about human nationalism or politics. It moves on in its inexorable course. And so even if you don't buy the ethical argument, which is strong, that we should be allocating the vaccine equitably across the globe to those that most need it, you have to look very carefully at the logical and common sense argument that if you try to sequester vaccine distribution in a given geographic population, you still won't likely be able to distribute it alone on your own, and B, unless you can seal borders and prevent movement of people, you must sort of equitably vaccinate people all over the globe. And so luckily, though this movement is afoot, there is a counter movement across many of the global agencies, including the Global Alliance for Vaccines and a number of multinational funders, to really say this is a global problem that needs global solutions, advanced market commitments, and other guarantees to give manufacturers of vaccines the ability to not just manufacture for one country, but rather for many countries, and to start allocating that efficiently and equitably. So I think that we saw a lot of this early movement play on. I think there's now, with COVAX, which is a sort of global financing facility and effort, we're seeing, I think, now a counter movement to that.
Okay, I know Christy may have some things to say about that, so thanks for introducing that topic. The other topic I wanted you to introduce, just to explain to us what it means, is this idea of herd immunity. We hear a lot about it, but I think we need a little bit of help understanding exactly what it means and how that might fit into this idea of returning to normalcy. So can you help us just understand that concept and how that might play out in this idea of returning to normalcy?
Sure. Herd immunity refers to the population dynamic in which a certain proportion of a given population needs to have immunity in order for a given infectious disease to stop the spread. Now, that immunity can be built either through innate immunity developing after exposure to the virus, or it can be built up through vaccines. Most infectious diseases are thought to require between 70, 80, sometimes 90% of the population to be exposed either to a vaccine or to the pathogen itself in order to build immunity. There is a lot of debate right now about what that requisite level is of exposure plus vaccination in COVID, because this is such a new virus from us all. Some scientists argue that the actual rate may actually be lower with COVID, but we don't know yet. What we do know is that even in the communities that have been hardest hit, that we're nowhere near on a population level, the level of immunity necessary to stop a second wave or subsequent waves. I mean, yes, there are some small parts of urban communities that have been heavily hit that have higher rates, but for the most part, as a country, we have about 2 to 3% documented exposure to COVID in our counts, and probably if we 5x that or even 10x that, that's not more than 10% of the population, or maybe 20%. We need somewhere north of 50, 60, 70%. Nobody really quite knows. And so the only way really to get there without massive human suffering and catastrophic healthcare pressure is through a vaccine.
Okay, that's very helpful. So I wanted you to kind of lay down at least that framework, that medical framework, just so we could have this discussion around trust and communications. I want to go over to Emily now and really sort of talk about start that discussion around some of those communications issues and some of the distribution issues. So Emily, you were the co-author of National Science Foundation study. And in that study, you suggested that this Operation Warp Speed rests, I think you said, on the compelling but unfounded presupposition that if we build it, they will come. And you said that past experience demonstrates that all segments of the population may not accept vaccines. And in fact, there's been some studies out, surveys out that show maybe up to 35% of Americans will decline a vaccine, even if it were free and FDA approved. So can you talk a little bit about what we need to do to, even if we had a vaccine, to start to address some of the steps that need to happen to address the distribution issues?
Thank you. I'm excited to be with you today. So this is a really big question, and I can talk about this for literally hours, but I'm not going to do that. I know I have a limited time to speak, so I'm just going to focus on three things that can be done, and then briefly mention two practices that will make those three things possible. So first, we need to have meaningful communication. And this means a couple of different things. First, there's some technological aspects of COVID-19 vaccines that the public needs to understand very clearly. The first of those is tempering right now public expectations about what vaccines will look like and what they'll do. The public really needs to understand things like there will likely be multiple doses needed. Some vaccines may work really well in certain populations, but not others. And it's possible that we may end up with multiple vaccines available where some of them are for certain groups and others are for other groups. So, and related to potency and availability as well, there are a range of possibilities, technical possibilities that really the public needs to understand. Relatedly, communicators need to persist in transparency around vaccine safety systems, and at the same time actively work to protect their integrity. Like Asif was just saying, the safety protocol, it has to be sacrosanct and completely apolitical. Beyond these technical aspects though, meaningful communication also, it literally needs to be meaningful to the people receiving the messages. And this means that there needs to be some tailoring that addresses the specific concerns and hopes of different communities across the US, and if we're thinking internationally, across the world. Having that type of tailored messaging will need to involve some foundational qualitative research, especially with more marginalized populations. And then also longitudinal panel surveys that can follow people through time, so that we understand as the pandemic continues and people's opinions and their concerns change, that the messaging can adapt appropriately. Second, we need to earn public trust in the fairness of the vaccination enterprise. Allocation strategies, which will happen when a vaccine is produced, pre-existing inequalities, and we're seeing some social upheaval going on in the US currently around those issues. And the politicalization of the pandemic that's occurring at increasing, and I would say alarming levels in the US, they all have the capacity to undermine public trust. So to overcome these issues, a few steps can and should be taken. First, the US government and state and local governments need to commit at this point to provide vaccines at no cost to everyone who wants one. That will take out issues about who has health insurance, who has the ability to pay, and who doesn't. Secondly, as allocation and distribution strategies are developed, they need to account for racial, ethnic, and social factors. And at the same time, we need to devise measures to assure the public that the allocation decisions and distribution protocol are consistently applied. And that consistency will need to be done geographically, and it will need to be done temporally as well. Third, we need to think about making vaccines available in safe, familiar, and convenient places. Mass vaccination that will need to occur to reach any level of herd immunity, whether that's 50% or 70% or 90%. We're going to have mass vaccination campaigns in the US. And we're going to need to scale capacity to manage vaccination on that level. As part of this process, it's going to be important for policymakers and especially state and local public health officials to consider non-traditional partners, so partners that exist outside of the clinical arenas. Possibilities include pharmacies where vaccines are already provided, but also mass vaccination clinics at places like grocery stores, senior citizen centers, workplaces, schools, or places of worship. The other thing that has to be considered in developing those sites is community trust. And this is really important among communities and populations, once again, that have been mistreated in the past. And I'll just give you one example for this. So in areas with large immigrant populations, for example, consideration needs to be given to sites that are convenient to access, but also sites that are away from police, from ICE officers, and from other persons of authority that may make members of these populations uncomfortable going to the location to be vaccinated. Likewise, and in particular for poor and underserved populations, consideration should really be given about bundling vaccination opportunities with other safety net services. So for example, if a mother was to take her children into a WIC clinic, bundling a vaccination opportunity for the mother and potentially her children at that time. So I could literally go into so much detail on each of these points, but there is a report and you can read all of the details there. So I'm going to end by mentioning two additional recommendations that are needed to operationalize my previously mentioned points. First, social science, behavioral, and communication research into COVID-19 vaccine uptake needs to be funded, and the findings of this research need to be implemented and integrated into planning efforts. Second, and this really comes down to an issue of trust, and especially as we're in a situation where politicians are making this, which is very much a public health issue, a political issue. That needs to be stepped back. And if we can't rely on the federal government to do this, this needs to start happening at state and local levels. And one really good way to do this is to switch the public health focus on working on behalf of communities to working with communities. For example, we could, at state and local levels, form public oversight committees that would involve members of the public, members of public health, some other knowledgeable people in this area, to be the ones that can review and report on systems that have impacts on public understandings of access to and acceptance of COVID-19 vaccines. That's a similar suggestion. We came up with this one in our report with the working group I was working with, but Harvard recently just came out with a similar suggestion in relation to vaccine safety in the FDA, to have a public oversight committee with that as well. That really can reform where the trust exists for members of the public and can be an important mechanism to improve trust throughout the entire process. So I'll leave it there.
Okay, well, thanks for all those points. Those are great points to build on, and we'll come back to a lot of those hopefully in a few minutes of discussion. I want to give Christy a chance to weigh in, and then and Alex, and then we'll come back and talk about all this stuff. So Christy, two things maybe for you to comment on. First, the Rockefeller Foundation has really focused on testing as crucial to the balance between reopening and forestalling the pandemic. Can you talk about what the Rockefeller Foundation is doing in terms of its recommendations on testing and contact tracing? I'm getting the sense from the discussion we've had so far that, you know, we do need to continue down this path of these tools that we've been using and do them more effectively. So I'm getting the sense that as we start to build our vaccine process, we're going to have a much better infrastructure to deal with, the social distancing and the testing, and that's what one of the focuses of your work at the Rockefeller Foundation is. So can you talk a little bit about that? You're on mute, by the way.
You know, you figure you'd figure out technologies by now, right? Thanks for having me, Brett, and thanks for having me on this panel, because it combines three of my loves, which is public health and communications and Texas. I grew up about 90 miles east in Orange, Texas, and so as soon as you said, "Can you talk with the Center for Houston's Future?" I said, "Oh yeah, I can."
Well, welcome
So,
home.
Thank you very much. Thank you very much. So anyway, yes, I work at the Rockefeller Foundation now, and what you're referring to is our national COVID-19 testing and tracing plan. We put it out in April. We put an updated version out in June, and let me give you a little bit of the background about why that came about. It was April when the shutdown was really getting strong and people were really struggling because they were losing their jobs or they weren't able to go to work. And it really became personal when people couldn't put food on the table for their families. And we became very concerned at that point that this was not sustainable. And so it was really affecting some of the communities that we work with the most. And we said, let's get together a group of experts and figure out what is it going to take to open the economy again. And so we literally pulled together a bipartisan group with economists and public health experts and industry experts and researchers. Pretty much if you answered our phone, you came to the table because we really needed to have a wide variety of thinking. And we tasked them and we said, what's it going to take to open the economy again in these communities safely, as safe as possible? And what they came back to us with was, you're going to need a lot of testing. We need to know where the outbreak is. And the only way we're going to figure out where the outbreak is if we do a lot of testing with rapid results. And so in the report, you'll see us refer to it as screening testing. I mean, the PCR testing is really good for the people that are in the hospital, but it takes time to get that back. It's an excellent test. What we need is something that businesses can have their staff test twice a week, or schools can test their children periodically. And these are antigen tests, but there's other tests coming out that could be just as good. The key is frequency and rapid results, because what we need to do is combine that with contact tracing. See, the catch is 40% of people are asymptomatic or pre-symptomatic. And so they're invisible, and yet they can still spread it to the people that they're with on the bus, that they're going to work with, that they're going to school with. And so the idea behind this plan is we have to find them and we have to basically isolate them so they don't infect other people. And the contact tracing piece of this is really new to this country. You know, we don't do it that much here, but if you look across the globe, every country that has contained this outbreak well did contact tracing. And the whole idea behind it is when you find somebody who has tested positive, you ask them to self-isolate, you find out who they've come into contact with, and you let them know, and you ask them to self-isolate as well. There's a lot around this. You have to make sure that they can have food, that they can have the services that they need. Companies have to play a role here and figure out that some people are going to have to stay home and self-isolate, and they still need to make income. So there's a lot of challenges here for business, but we believe very strongly. In April, we had 1 million tests a week. We believe that by June, July, we need 3 million tests a week, and we got there in this country. Really, really good progress. But by October, November, we believe that we need 25 to 30 million tests a week in order to be able to contain the outbreak as much as possible and help reopen the economy and keep the economy open. That's the whole idea behind this, is creating a sustained reopening of our communities and of our institutions. That's what's behind it, but check out the plan if you want more details. I know I crammed a lot of information in there, but that's the idea behind it. Until we have a vaccine, this is the next best thing. And as you said, Brett, even when we have a vaccine, we're still going to need testing because we're not going to have enough vaccine for everybody. And that's when the communications message gets really tricky, doesn't it?
Yeah. I want you to put that communication. By the way, we put the link to the report into the chat so people can look at it. But I do want to put you to put your communications hat on, because you've done this for so long in so many different countries. And Emily, you talked about meaningful communications. Just kind of give us your experience on what it's going to take to meaningfully communicate to the public and earn public trust?
Are you talking to me or Emily?
No, to you.
Okay.
To ask you to comment on some of Emily's suggestions.
Yeah, Emily's suggestions are rock solid for sure. You know, really, it's all about trust, isn't it? You have to have that trust before you need it. And trust takes so long to build, and you can undo it so quickly. I mean, the things that we know about trust in public health is transparency, like she said, especially when we're going to have a vaccine, we're going to have transparency and openness about how we're choosing who gets the vaccine. But a couple of other ingredients that we also know that really help create trust: empathy, expertise, dedication to the community. You know, that your community knows that you're with them and that you will follow through with them and that you will be there with them through it all. You don't have to have all the answers. You know, you just have to let them know what you know when you know it, let them know what you don't know, and let them know what you're doing to find out what you don't know. Disease outbreak is a team sport. And the sooner you can connect with that community, the better the outcome is going to be, because then you can create that culture of everybody looking after each other. And that's the whole idea behind the mask. You know, you're protecting the people that you care about around you. You're protecting yourself some as well. But getting this idea of we're all in this together is really important. I'll tell you something else, Brett, that we've learned is really working with the local people in the community. We learned this during Ebola. I was leading global communications for the World Health Organization. And one of the big lessons we learned is that the local community is the trusted. And there are influencers in that local community. I mean, we were working in West Point in Monrovia, in Liberia, and they were rioting because they couldn't get the help that they needed. And we went in and we met with them and we said, help us help you. What can we do? And they said, teach us. They said, teach us what we need to do to protect our community, and we will do it. And we will take care of getting the bodies out of here, and we will take care of getting people buried safely. They trust us. We can go into the houses and do that. And it was a message that really stuck with me over and over, because a lot of times we think, well, they're the smartest person in the country, or oh, they're the grandest person in the country, but they're not the ones that are going to connect with that community. And I think with COVID, when we see the differences in the expanding and contracting of the outbreaks in the different communities, that local trust is what's going to help us get out of this as safely as possible.
Great. So I want to go to Alex because he's been doing a lot of this work in the Hispanic community in Houston. And Alex, you know, you're not a medical professional, but you are an advertising guy, and you've been working in this field, and you know this community. So tell us a little bit about what you, from your perspective, what you think works and what your experience has been.
Well, first, I want to thank you and the Center for Houston's Future for having me. I'm truly humbled to be with this panel. You're amazing people doing amazing work. And as Brett said, I'm the ad guy in the room. Well, you know, it almost sounds like we kind of had a meeting before this panel, because I think we're all fortunately speaking from the same prayer book. And I think that's important. You know, we learned a lot by doing this particular work on COVID-19. And what we learned, two key things. We learned first that more than ever, we do have to have a disciplined, fact-based, culturally competent and relevant approach is what is needed. Now, that's kind of how we always have gone about our work, you know, very fact-based, very methodical, and, you know, we always put the customer in the middle. So that's, to us, it's not just about throwing out there the messages, particularly in Spanish. It's about being very, very thoughtful and applying a certain amount of rigor to the creation of the message and the dissemination of the message, because we must meet the community on its turf, every single consumer on their turf, both emotionally and practically. The other thing we learned is a lot of what makes Latinos Latino, what makes us us, which makes us great consumers, and why a lot of corporate America is targeting us. You know, the fact that we're so much younger as a community, that puts us smack dab in the middle of the top of the consumer curve. We're buying our homes, we're buying appliances, we're great consumers. and other things that make us such great consumers. In this case, some of those wonderful things are not so wonderful. Let me get into that for a second. When I authored the piece on Latino identity, you start getting into the contextual factors of identity and then the defining factors of identity. You find the defining factors being, of course, spiritual beliefs, family dynamics, our sense of space and time, social and hierarchy models, and the fact that Latinos, by and large, we are a we people, not a me people. So what happens when that is in place? One, you look at our social habits. One, we gather, and we gather a lot. Let's take Mother's Day specifically, which happened at the beginning of the onsite. We don't have the typical Mother's Day with, oh, just my mom or maybe my no, it's any mom in my circle we celebrate. So we've actually done I don't want to say shop-alongs, but gather-alongs, where we might have 40 to 50 people on a given Mother's Day celebration. Two, we are a very affectionate, warm, touchy-feely kind of people. So what happens? I mean, half of my emails, I sign un abrazo, hugs. You see men hugging, we are that. So all of a sudden, you're taking away my opportunity to gather as a community, to gather as a family. You're taking away my ability to say, dame un abrazo. I mean, how many times since March can I tell you that I have gone into the room, mask and all, and I've stopped myself? As aware as I am of the issue, you stop yourself. So, the fact that we live in multi-generational households, that is something we do by choice, and so, of course, you have different challenges with that. You have larger households, you have the potential for more infection, and then also you have families who are really challenged because if you have an elder in the home, and sometimes it's 2 generations of elders, boy, that whole family is really at risk and it paralyzes the family. And then lastly, we are avid users of social media. And so when you have a population that is consuming that much input, boy, you can get a lot of different messages at the same time, and a lot of those messages have been conflicted. However, the one thing I did predict at the onset of this is that we will go, Latinos went to their trusted voices. When in doubt, we have a very, very stable and solid infrastructure of trusted voices. Our own set of influencers, but you start with Univision and Telemundo. I mean, those are folks that have been giving us our news, our information, in pretty much an apolitical way, believe it or not. When you look at the polarization that we have in the general market, we're on the Latino side, you don't have it that much. But those are our trusted voices. The Univision and Telemundo, they've been at this, helping us understand financial services. They communicate to us the issues and the challenges on immigration and immigration law. They give us the news from our countries of origin. So those are the trusted voices. The Jorge Ramos of the world all of a sudden became super important. Terrestrial radio, not dead. A lot of people keep saying terrestrial radio is going to die. Not in our world. Terrestrial radio, why? Because it is eminently local, and because those DJs aren't just those personalities aren't just spinning records and going hoo hoo ha ha. They are actually trusted voices for us. So what we did is that we really went at this quite methodically. First, we developed a clear understanding of the population at play. Now, Houston is my hometown, but I do have to tell you, it's everybody's hometown here. Welcome back home, Christy. Houston is one of the best Latino markets in the nation. Very unique in some ways because it is very diverse. We have Latinos from everywhere. We have an enormous bicultural group, which is US born. So it's typical and prototypical in some ways and not in others. Let me give you some of the numbers that I think are relevant to what we've been doing on the COVID-19 front. And these are things that we have to really take in mind. First, Houston, as the metropolitan area, is Latinos comprise almost 40 to 45% of the entire population. 78% of Latinos live in households with 3 or more occupants. 78%. 58 with kids. Now, put your mind around this. 61% of this community is Spanish only or Spanish mostly. Now, there's another side to that coin. 43% are functionally bicultural, which means they're either Spanish mostly, English and Spanish equally, or English mostly. So you have to really think of your messaging, not just in language, but also in culture. Now, the latest survey I have says that my trusted voices, remember I talked about that? Spanish TV, 58% of these households consume Spanish language television and 69 Spanish language media as a whole. So these are folks who are consuming Spanish language media by choice because they are functionally bicultural and bilingual. That's an important thing. You know, when I started the agency 35 years ago, you really had people who had to consume Spanish language media if they want to know, is it going to rain today? Is there a wreck on the freeway? They're doing that by choice now. And that's a really important distinction. So once we have a really good idea of who we're talking to in the profile, we develop personas and we really get into understanding you know, their demographics, their psychographics, their technographics, their behaviors, and how can we reach them and where can we reach them. Then we also go into really getting into, okay, what are the barriers of this message? You know, what are the fears? For example, some of the fears that we face. Now, I'd like to say that we did a great deal amount of research in the building behind me. We have a research facility, and we conducted a qualitative study that was fairly extensive. But we got into issues of, okay, what are the fears? Financial, as Emily said, immigration. You know, those are some of those issues that are, okay, I can't go get tested because, I can't go get information because. The fear of life interruption and the impact is incredible with COVID-19. Then you've got the oversaturation of messaging between the CDC, the fraudulent entities spewing all this stuff on social networks. You have a lot of misinformation happening there. So then you have to move to, okay, how do I make my messages culturally relevant, contextually relevant, and how do I meet this consumer where they are? So then we get into the design of the ecosystem. It's not just about mass media, far from it. You really have to look at the design of an ecosystem that is far more sophisticated and far deeper. And you go from inside out. So in both Emily and Christy, I think you both mentioned the importance of those trusted voices and those trusted places. So of course we start from the inside out, my inner circle. If I see school teachers, my kid's sporting coach, other parents that I'm talking to, doing taking these steps towards prevention, no, then I'm not that crazy. Now, keep in mind, again, I said that we are a we collective, not a me community. So if it's good for my community, good for my family, whether it's inconvenient for me or whether I believe it or not, if it makes them feel better and if it seems to be working, then I'll do it, okay? Then we get a little bit beyond that circle. Ministers, churches, you talked about atypical partners, the consulate. Consulates are very, very, very important. Or immigration attorneys, construction employers, the Hispanic Chamber of Commerce has had an amazing presence during this period. So what you hear out there is, if they are Latinos and they are educated Latinos and they're in a position of influence, then I'll pay attention. And then you go a little bit further beyond to, like I said, personalities, doctors, certain celebrity figures, and even retailers. You take a retailer like Walmart. Walmart has been making serious deposits in their trust piggy bank with Latinos for a long, long time. They were among the first major retailers to really get in there and really invest in talking to this market. And that starts paying off over time. They've got a very, very solid trust bank. So other retailers, You look in Houston, retailers like Fiesta, some of your smaller retailers, but they're quite endemic. They become very, very important. So that's kind of how we've gone about it, quite methodically and quite thoughtfully, like we do with anything else. But I think that here, being respectful, being thoughtful, and being fact-based, and really getting in there has made the difference for us so far. But the job is far from done. I mean,
Good.
we have to keep going.
Okay. Well, we have a lot of questions. I do want to open it up before we go to questions, just the other panelists to comment, go back around and let folks comment on any of the other panelists. Just some have a little discussion between the panelists and let you guys comment. Emily, I saw you might have something to say, and Asaf, I know you've lived in El Paso, so you might have something on the some of this may have rung true for you as well.
Yeah, I just wanted to second what Alex said. It seems like we're all coming from the same prayer book with this.
Yeah.
And everything that you said, absolutely. And really, once again, working with communities involves, finding community spokespeople, going through those networks of trust. And that's really going to be critical. That a lot of times we think about vaccine development as this huge endeavor, but the social components around uptake are as complex and need equal amounts of attention.
I think also you have to train those trusted voices. You have to really give them the materials. And again, back to the prayer book, you really have to be very consistent and empowering. And as you give that information, that it's consistent, that you repeat the same words, that our community hears the same message from those trusted voices in a consistent way. I can't put that out there enough.
Alex, one thing about that, I was going to jump in for this. One thing that we're looking into is actually working with those trusted sources. We have a project going on in Africa right now because we're trying to deal with the misinformation and the disinformation that's out there. And the approach we're trying to take to it is actually to get to the ground. And if we can actually work with those influencers in the community, whether they're entertainers or politicians or media, whoever they are, if we can arm them with the facts and give them the resources they need, I am certain that they will shut down misinformation and correct disinformation whenever it comes their way. And I think, actually going that direction is a really powerful thing we can do to keep the actual facts going strong in the communities so that people trust what they can do to take precautions.
And I think also speed becomes really, really key, Christy, because when you hear a message of misinformation, misinformation pops up quick and fast and everywhere. It's like bad weeds. So you really have to say, okay, I heard that. Is it going to spread? Use your trusted voices to dispel it quickly. You can't wait.
That's exactly right.
Yeah, one of the, just to build off of that, Alex and Christy, one of the unexpected partnerships, COVID drives you to unexpected circles when you're in public health field. And our vaccine team has partnered with Netflix and putting out a multi-part series exactly to what you're speaking about. We have to get outside of our usual communication channels, our usual walls, or even our social media lanes to really build that kind of clear, actionable, fact-based, accessible, and vivid, compelling reasons to take on what is difficult. I'm a primary care doctor. I see patients, and what is one of the most difficult things, even not outside of COVID? It's getting people to engage in their health in a partnership in which you ask something of them, you recommend a preventive medication or test in which they gain no immediate benefit. There may be a slight risk, and they may not ever get a benefit. So, that's quite a discussion to broach, and that's what we face with vaccination, in that we are asking communities to get something in their arm that may have a small risk, But it's in order to build a social compact such that we can actually exit this crippling pandemic. And that, in an age of deep individualism and deep, I've got my facts and you've got your facts, is a steep challenge. And the only way forward is what, you, Emily, Christy, and Alex have explicated. It's not the doctor and the expert thing, it's the community-based participatory trust process.
It's interesting because there is so much in the US in particular, and I saw this in something that Michael Sandel wrote, which I'll actually circulate. It talked about individualism versus social cohesion. We do have a question from Catherine Tarrant in the talking about that. We're such an individualistic culture, but it seems like this problem really requires us to think more collectively. Is this going to be a problem for us in the US, do you think? To think about this as a problem that we all have to solve together as opposed to individuals? Are we just not programmed to solve this problem in the US?
I would say it's a culture change. I would say that it's a culture change, but we have seen this happen before. We know how to do it. In fact, you've really got the expertise represented here that it takes to do it. I go back to HIV back in the earlier days of that pandemic in 2000, and one of the worst places in the world for new infections was in Russia. And the government was investing next to nothing in trying to contain it. And there was a group of people who went in, public health people, who went in and got the leaders of the media outlets together and basically said, you know what, you have a social responsibility to your communities. You need to commit X amount of time every week to be spent on addressing HIV, reducing stigma, normalizing it, getting people to talk about it, and we need to create a grassroots demand to have invested here. Well, what they did was radio stations started talking about it. Entertainment shows would put a character in that had HIV. The news stories, of course, covered the news angle of it. But it created what Alex was just referring to, where every time people turned around, people were hearing about HIV. And it did that, and it reduced the stigma of it. And pretty soon, people were realizing the magnitude of the problem in Russia. And within 3 years, there was such demand for recognizing HIV and helping to overcome it in the society that they went from like $12 million of government investment to like 200 million in government investment. Don't hold me to those numbers. But the point being, yeah, you can change a culture. You can change a culture to do whatever you need it to for public health. Because I think deep down inside, people are kind. And people just need to be pushed in a direction to show what a new normal is. And I'm a firm believer that with good communications and the right techniques, you absolutely can change a culture. It takes time. I think we can.
Yeah. On the Latino side, I'm happy to report that it's, like I said, I've said it before, we are a we collective. And so I think that the culture change won't necessarily be there.
We need to learn from you.
Addressing but it's also about helping address some of the fears and barriers that are real and some just perceived. I think Emily addressed some of those. That's where the hard work is going to be.
Yeah. Well, this has been such an interesting discussion, and I know we're going to run out of time quickly here, but I did want to there has one question, and not to open a completely different Pandora's box, but at the risk of doing that, I'll do it, and it'll give Asaf a little bit of time maybe to talk about a program he's working on, which is K through 12 health. How do we communicate risk, in a reasonable and understandable way to parents? That's one of the questions that's been asked. We're sort of at an impasse here in K through 12. It seems like. So, why don't we spend just a minute or two talking about that, and how do we get kids back to school? So that's a question that's come up in some of the questions that have been in the chat.
Real softballs you got there, Brett. Really.
I know that. Sorry about that. In 3 minutes or less.
No, I mean, because it's such a massive topic, I'll just point you in a couple directions. Look, this applies both to vaccines and schools. I think that we have a narrative that's built up in our polarized society right now that, America and Americans don't believe in science and don't believe in facts, and this is all hopeless. And I'm with Christy. I disagree with that. I think that this is, we are going to be able to overcome this. And, I think that we need to be more creative. We in medicine and public health and in the health related spheres, people regularly, as in like every day, and before the pandemic, they did this with, every day people step in cars and every day people step in airplanes, or they used to mostly. And that to me is quite clearly a larger leap of faith. Like, you must believe in a lot of key principles of science in order to get into a metal tube, to shoot you up in the air. And, there aren't a bunch of gravity deniers or airplane deniers out there. And I think that the conversation I'd like to have is, if you believe in science enough to step into a metal tube to shoot you to 32,000 feet, I think we can have a conversation, and we can, with appropriate proof, show you the steps that we've taken to put this vaccine in your arm for the good of yourself and your community. And that's a conversation I'm willing to have, and I think we need to be willing to have. The way to relate it to the school question is, and we're not gonna be able to get into the whole thing, but there is no one answer. It is really complex. I'll send you to some resources. But one of the key things working with the school superintendents and with teachers and with parents that's been really important is what we call having a balanced view of risk. And that's really taking everybody's risk and everyone's perspective into account. So it's really to say, yes, there are risks of COVID transmission. There are probably age and health related conditions mediated, meaning that people who are older and have health related conditions are higher risk. Kids who are much younger probably have lower risk. And we also balance the risk of COVID in kids and in teachers with risks of not going to school, risks of social emotional learning loss, risks of less domestic violence, less child abuse screening, risks of food insecurity, risks of economic dysfunction in society. They're not equivalent, but they must be balanced to have a rational conversation about what in a community, based on its transmission rates and its mitigation plans, whether that community is ready to reopen schools or not. And if they're ready to reopen schools, what are 9 steps that you can take that we kind of call a public health playbook to reduce that risk. So I'll point you in the direction of some information that we built with school districts and parents, and I guess leave it at that.
Okay, good. Well, I wanted just to give you a chance to put that out there. I guess it's called the Bravo Project. Is that right? And just I wanted to, I know we're at the top of the hour. I just wanted to thank all of you for what has been an amazing discussion. We really have covered an immense amount of topics and area. And, I will just say to all of you, my confidence and trust has certainly gone up in terms of that we can solve this problem. And I really want to thank all of you for all that you're doing to get us back to what we want to see, which is the reopening of our society. So I know that you all haven't worked together before, but I suspect that you might be doing some more of this work together going forward, because you're all working in the same area and are really doing great work. So thank you for being part of this and spending a few minutes with us, and really having a great conversation. And I know it's been a great opportunity for us to learn from you all. So thank you very much for your time today. Take care, and we'll be in touch.
Thank you.
Thank you.
Thank you.